Yes, here we go. All right, everyone. So, hi, my name is Shahriar. I'm going to start today's session. Today's session is on GIT. In the beginning, let us know in the comment section from which city or country you are attending this particular session, actually. So, in a minute, we're going to start this session, actually. Thank you for waiting. It's, very early days. So, that's why we're taking, 3, 4 minutes to start up. So, in the beginning, please mention in the comment section from which city or country you are attending this particular session. I hope I'm audible to all of you at the same time. Oh, good to see Edinburgh, beautiful city. I've been there. Great. All right. All right. Brazil as well. Okay. Few doctors also passed from the Brazil. Yeah. Get in touch with me. Maybe in future I can also guide you. I mean, those people are working in Australia from Brazil. Maybe I can guide you. I mean, if anyone from the Brazil, actually. So many from India, Bangladesh, Pakistan, of course. I also have seen in last 2, 3 years a lot of doctors from Brazil. I mean, also taking interest in MC or courses. So it's quite a common. There's another group from these particular countries. They already migrated to Australia and already they're studying or they're in a visa, spouse visa. I mean, their destination is fixed, so you don't have much time. Guys, do you know today's topic? Yes, and today's topic is GIT. And I'm going to take this session. My name is Dr. Shahriar again. If anyone has just now joined, actually, I've been a tutor for 9 years. Actually, under my guidance, there is more than like 1,900 doctor past. As far as we know, like it's over 1,300 doctors are working from those past from our academy. Actually, I'm sure you will be one of them in coming days. Then we have done the rheumatology, and today after the session, I'll be uploading the mock. Remind me, I mean, so definitely. And here we go with the GIT. Are you guys ready? Yes. So GIT, how to solve GIT, how to go through the GIT. This section is about that actually. Okay. So regarding the GIT, as you all can see, regarding the GIT, I have highlighted few things. Of course, we will be going through the theory, which is mainly based on the John Mortag based theory. Then there will be class recalls. That's like the last Thursday we do the recalls actually. Then there will be this question bank actually, so we'll be posting the question bank. Once we'll close the group actually. We haven't introduced you to the question bank, but there are question banks like Amedex, Implux, eMediCeres question bank. We'll also upload offline version for you. That is also enough for the preparation actually, guys. Yeah, so no problem on that one. And like probably we'll also guide you after GIT next class, how to utilize the forums actually. Okay, we have a forum like Shares MC guideline forum. Let's say if you use something like, let's say, the word GIT, and if you search into that forum, the forum name is Shahriar's, AMC and guideline. That's a very like popular and quite a like early days group. And in that one, actually, if you search with this word GIT or hashtag GIT, or you can search with individual topic like echinacea, like then there's like barium. There's any important keyword. If you search, you will find relevant question, recent, past. You can also solve them. Guys, is this plan is so far clear? One, in the Sunday, we are taking theory class for you, guiding you with all important necessary things from John Murtagh, from checking the SMA notes. Then coming to the Thursday class, that is the recall. Like I'll guide you with all necessary important topics regarding the recalls. Actually, if you attend the class recall, it will cover like, kind of like I would say 80-85%. The remaining that 20%, I would say you have to hit the forum and keep checking. There's nothing called 100% actually you can take a preparation. So, I mean, we try to bring all the necessary types and the new types. So, classic ones and the new ones. That is how we know we designed our course actually. And then the question banks that helps you. It's not a like something always comes to the exam, but that helps you practicing first. I mentioned last day, and then comes the forum. Let's say SAMC guideline forum. We keep posting questions, so many questions you will find, and you should keep solving those questions. That can be really, really important. And last but not the least, finishing with the mock. Mock, we take the small one, offline one. We'll upload the file one. You can download the file. Okay, so we will be giving you that one. And of course, once the medicine will be over, then the computer's thing will start. Will make you used to with how things are in AMC exam actually. All right. Are we clear about the initial plans, guys? Please let me know in the comment section. Are you getting the plans, guys? Yes. Okay, that's the plan. And so we're starting with the GIT theory today. And yes, so I want you guys to open the John Muttak. Also, as like I'm using a laptop and a headphone, this kind of setup is very, very important to hear well, to see well. Actually, that's the thing. Should be actually, and you can also interact with the Zoom chat box. We also have inquiry zone, especially in the live classes after class. You can also ask me things there actually, and I'll follow up definitely. If not the same day, maybe in 1 2 days, I can definitely get you back on that one actually. GIT overview, guys. Did you see the GIT overview, guys? Very important. Like what topics I'm going to cover, you are supposed to know by this time. I mean, what topic generally I'm going to cover, you're supposed to know by this time because I posted something called the GIT. If not, maybe you can check that group, that batch uh, currently you are in Facebook. You can check always that group actually. All right, so you have to be a little bit smart in terms of social media handling, or if you are not that much good in social media, you should have a connection with 1 or 2 friends who can also help you actually. Okay, right. Okay, books recalls key points. Yeah, so yeah, yeah, that was my question. How many of you have seen the overview? I think most of you have seen the overview. If not, you can go and check. Overview theory, recall, mock question bank solving, very, very important. Question bank, Amadeus, MPLUX, MC question bank, and also that e-medicine bank. Actually, yes, one question bank is usually enough. Anyone, if you solve properly, it's more than enough. That is the thing. Yeah, don't miss out live classes. This is another very important information to all of you. I mean, no matter you see the recording later, but please make sure you attend the live classes. We have a study or research that those attended live classes and also check the recording later, their passing rates are better than others actually. All right, and I mean, of course, I'm going to guide you regarding the GIT, esophagus, then stomach, then intestine, and some this yeah, anogenital areas, post the surgical section, and immediately miscellaneous. All right, so this is the plans. These are the plans, and let's get back to this particular part, like the esophagus. In the esophagus, can you mention about some diseases? Can you mention me about some disease about the esophagus? Definitely. Okay, starting with a lot of things, like starting with the very, very basic, like the CERD. ZERD is one of the, then if you name ZERD, then achalasia. One is a reflux, one is a tightest sphincter. We'll get there one by one by one. Tell me more about it. Yeah, Barrett's esophagus. So if you know ZERD, you should be also knowing the Barrett's. Yeah, Barrett's. Anything else? Esophagitis, because it's ulcer, so it's always irritating that part. So uh, esophagitis. Esophagitis. That's another term. Then the more danger one, the one that is the cancer. That's the cancer one. All right, now coming some additional things, two things to remember. Mallory, ways. Mallory ways, and there's another one to remember. What is that? Boerhaps. Okay, Mallory waves and the Boerhaps, these two names, you have to remember these two names together. Mallory waves and the Boerhaps actually. Okay, then comes the nutcracker, this, that, that's not that necessary always, but this Boerhaps thing is very, very important. Another thing, there can be bleeding in the lower end of the esophagus, like esophageal varices. That's more related to the hepatobiliary uh, things as well. As the time continues, we'll solve more things actually. Esophageal is important, ulcer is important. One more thing, we talked about the reflux, we talked about the irritation, we talked about the ulcer like esophagitis or any esophageal ulcer. We talked about the rupturing of the esophagus, that's like the Mallory ways, Boerhaps, there's like there will be tearing of that one, but we didn't talk about the allergic part actually. So esophageal allergy is known as, what is that? That is eosinophilic. Eosinophilic, eosinophilic esophagitis. Okay, so that's the allergic part actually. Allergy, eosinophilic, esophagitis. Clear, everyone? So these are the topics I need to cover, and then we'll get into the stomach and many other things. Let's get into John Murtagh without any further delay. I hope you guys are ready. So if you open your the John Murtagh, I recommend you to open up the page number, this one, that is 447 ninth edition. 447 ninth edition. We'll be definitely needing the ninth edition actually. All right. So 447, that's the, if anyone using a other book, in that case, maybe you can just find out the dyspepsia chapter and then open it. Okay, now coming to this one, 447 page, and in 447 page mainly we are opening this particular part is 451, our next title topic, that is CERD. I ask you guys another day, do you guys like drawing? Do you guys like board drawing type of thing? Yeah, many of you mentioned as a yes, you like board drawing actually. I mean, some of you like, probably. We just have to make a balance so that we don't waste that much. No, this is a normal thing, right? This is very normal in stomach. But what if these areas are changed? These areas change, and especially this part actually, too much uh, lax, relax. Okay, like normally whenever the food goes in a normal stomach, this part like closes very fast actually. If this part like fail to close in time, actually esophageal, some sphincter related issues, that leads to one of the lower esophageal sphincter. Yes, lower esophageal sphincter. If this part by any chance is not closing in time, that means too many acid content from the stomach goes into this part. Now, is stomach and esophagus has same lining? That's an interesting question. The answer is it is a not actually, because they have different lining actually, right? So when the acid started to going from this particular to that area, and the lining epithelium is not same, and there will be some changes over the time actually. Okay, so metaplastic changes that can happen, but that's a long term game. But this backflow, the line is called backflow, is also known as reflux, and this is your classic GERD case. Are we clear? This regurgitation means backflow, means when the acid is having backflow, it's causing the irritation actually. Now, if you do a very simple test as an investigation, like a normally, we get to know by clinical. Is GERD is a clinical diagnosis, guys? What do you think from your practice? Is GERD mostly a someone you see obese and you say, doctor, I have some bloating, I have some, and you see this person, he have digestion problem, or okay, by night you feel bad. Yes, at the night time I feel even more bad actually. So that means you're the person is having classic GERD. And yes, tests are available, like you can do barium and you can confirm the test. Now, one barium is the initial and confirmed by 24-hour pH monitoring. 24-hour pH monitoring, that's a confirmatory. So for textbook, it is necessary. But honestly speaking, that mostly what we know for GERD, the diagnosis is clinical, and even the treatment. Do we do the investigation? What is our approach here? Do we do the investigation first, or we give a trial of PPI first? Think. So what is the right approach? Trial of PPI, like you see, like for 2 weeks or for 1 month, the doctors are giving a PPI treatment, and the patients are doing well. So the clinical thing, so it's like a 4 weeks, 4 weeks PPI 20 mg. That is the initially first actually. Okay, then the point of barium 24-hour pH, and if 20 milligram is not working, we can increase it up to the 40 milligram. Am I right, guys? So these are two things. PPI 20, we can extend it up to, so double the dose. So here's the term we are using, double the dose if things are not working. Have you seen a lot of people need 40, like the PPI, Pantonics or Sunobrazole, they might need the 40. Yeah, like, so that's one of the thing. So here we go. Again, the ZRD, lower esophageal sphincter remain relaxed actually. And because they are obese, so the muscle gets loose, and whatever the reason, anatomical thing can be reason. Now there's a backflow, and backflow is irritating that part. So acid reflux, this reflux is ZRD. We do the barium and treat for pH. But before doing barium, it's often a clinical diagnosis. So we give 1 month or 4 weeks of trial PPI. If it's not working, we can go for a 40 milligram. Now, Is it possible that in GERD cases, sometimes we may need to do a endoscopy? Now it's getting complicated. Some cases we might need to do an endoscopy. The question is when. This is an exam question. All right. Now some cases we have to do an endoscopy, and that is if there is any red flags. Red flags means if associated with weight loss, if associated with, anemia, if associated with any symptom that is going towards the cancer. Any symptom that's going to the cancer, I'll show you the red flag points. So if any red flag, then only we do the endoscopy. Whereas in cancer cases, we directly like consider doing the endoscopy quite an early actually. Because in cancer cases, the red flag is present from the very beginning. Is it clear? Like when barrier, when 24-hour page monitoring, when in special cases, endoscopy. Are we clear so far? Indeed. GIT related, we have a SMA note given in the note section. Please also check it one time. It will be helpful for you in that case. Now, it's time to go to the John Murtagh, how the patient presented to you, a adult patient. Now, remember, there will be adult one, there will be also children's one actually. So, adult one will complain about, heartburn mostly. Patient will, okay, this indigestion. Indigestion is causing a lot heartburn. One big difference which you can write near to your John Murtagh 451 versus achalasia. Is achalasia having any heartburn? Simple question. Is achalasia having heartburn? The answer is a no. Achalasia has a tight sphincter, so the acid reflux does not happen, so no heartburn. So GRD, yes for heartburn. Achalasia, no for heartburn. Always GRD compare with the achalasia and the cancers. Okay, so here is they will say okay, bloating, burping, this kind of thing. Nighttime more symptoms. Because nighttime we are sleeping now, more symptoms. So is it helpful? Lifestyle modification, do exercise, using two pillow. Is this thing helps? Yes, in this still helps. Red flag pointers for endoscopy. See anemia, dysphagia. See in esophageal cases, dysphagia is a big term, but dysphagia is an early symptom. The answer is most cases it is not. Dysphagia is often not an early symptom. Dysphagia often comes much later. Okay, so that's one of the thing. All right. So here we go, and yes. Now, few complications. Let's talk about actually. Okay. Now here is the thing. Few complications. Let's talk about. In this case, highlighting. Yes. So complication. Now let's correlate. It's a acid reflux. So there will be irritation in the lower esophagus, and that is causing esophagitis. Am I right, guys? Yes. And esophagitis eventually leading to ulceration. Am I right? Initially irritation, then there is esophagitis, then eventually more burning, and there will be ulceration. Eventually, that part can be bleed out, and there can be anemia or possibility of cancer in future. So it can be anemia. Now, this part is burned and eventually can lead to stricture. Now, you see, think in this way. That's the picture that if this part is keep hurting, there's fibrosis, and again there is ulcer, again fibrosis. Is this part is getting narrowed? Yes. So in this way, it is a possibility there will be stricture. Clear now? Yeah. So there will be keep healing and keep burning, so eventually it would be like a lot of fibrous tissue, it will be narrowing and there'll be narrows and there'll be stricture. Some cases, that is called the correlation. Last day we have discussed that GERD very strongly correlation with asthma. If you check the Davidson's medicine, when they have a box, 30% of the GERD cases related to asthma as per the Davidson. Okay, so all these things one side, and here the barium, this thing in another side. We'll talk about this thing a little bit now, actually, about this barium thing. So come back to this barium, Barrett's esophagus, but we talked about the investigation of GERD. It's usually barium, then confirmatory is 24-hour pH, 24 pH. Initially, it is barium, and some special cases, endoscopy. Now, you can see mostly it is a lifestyle modification, avoid smoking, avoid junk food, avoid heavy food at a time, small and two pillows. And main stage, the treatment is a proton pump inhibitor, 20 mg. And if you go to the next page, they also mentioned about the 40. Okay, so you can double the dose actually. You can double the dose. Long-term treatment of GERD is a weight loss. Also for hiatus hernia is another thing. It's a part of our surgical topic, but hiatus hernia is very strongly correlated with GERD. Do you know this information? Hiatus hernia very strongly correlated with GERD actually. All right. So you can see there's two types are given: sliding hiatus hernia, rolling type of hiatus hernia. Okay. And they're, long-term treatment. So they have GERD-like features, first of all, mostly asymptomatic, but GERD is a common. So you need barium eventually. Barium will show you. And so type sliding and the rolling. So bulge of stomach herniates into the chest. So that's the danger part. Okay. Now, long-term treatment of hiatus hernia is a weight loss. Long-term treatment for GERD is also weight loss, actually. If it is a hiatus hernia, you probably need a surgery at some point, especially if there is a rolling type of hernia. So this is a added information. Hiatus hernia, usually conservative weight loss, but you might need surgery, especially if rolling type and being a little bit more advanced. Okay, we are talking about this last page, which is the Barrett's esophagus. Now let's get back to the drawing part again about the Barrett's esophagus. Okay. Now, next topic is coming the Barrett's esophagus. I'll write few things. I want you to write it down. So Barrett's esophagus. I hope you like the mnemonic thing. Let's start with this word BCS. What is BCS? In Barrett's, columnar replaces squamous. That's interesting. In Barrett's, columnar replaces squamous. So can I say in Barrett's esophagus there is the lining would be columnar? Now is normal esophageal lining is columnar? That's the question. Is normal esophageal lining is columnar? No, it's normally squamous. Now there is a change, and this change we called double edge, double edge like a sword. Okay. So Barrett's esophagus, columnar, which is called the double edged sword. Now, in this case, is it a good change? No, it's a metaplastic change. Metaplasia. Metaplasia. Eventually, this can lead to cancer. Am I right? This can lead to cancer. So this is the esophageal thing. I'm drawing the bigger one now. Okay, so esophagus we divide it into upper two-third and lower one-third. Okay, so this is more common in the lower one-third. So we remember this thing as a one-third AB. One-third means lower one-third of the esophagus. B for Barrett's. And this A for what kind of cancer can anyone tell? Yes, and this A for adenocarcinoma. So can we say in Barrett's you are expecting what type of cancer? Adeno, and this is the exam. Often it's given in the exam. So in Barrett's you are expecting adeno. Whereas in upper two-third of the esophagus, we'll come to the cancer part again very shortly. So we'll see these things again. So upper two-third is related to squamous. Yeah. So upper one-third is related to squamous cell carcinoma. So adenocarcinoma, squamous carcinoma. We'll come to the cancer very shortly, but this is a information about Barrett's. One more additional thing to learn from the Barrett's is, you need to follow up. It's a risk. Am I right? It's a risk. So how persistently you'd like to follow it up? 6 months, 3 months, 1 yearly, 2 yearly, 3 months, 6 months, 1 yearly, 2 yearly. So please write it down near to this. You have to follow up this thing for, yes, you have to follow up this thing for 2 yearly. This is another exam question. This is another exam question. So 2 yearly follow up for this particular condition. So this is also given in, yeah, in the next page, 454 page. It's mentioned Barrett's. Those points I mentioned, you can also write down in a piece of paper and also can add this thing. So during the class, you can write few things, it's fine. So 2 yearly follow up with the endoscopy. This is a very popular exam question. Very, very popular exam question. Okay. We're going for the next one thing, which is page number 450, dysphagia. Dysphagia is nothing but difficulty in swallowing. And there's another term to memorize, which is odynophasia. Do you know what it is? Yes, odynophasia is also difficulty in swallowing, but at the same time, it's a painful difficulty in swallowing. Painful difficulty. One is a difficulty in swallowing, just difficulty. One is like you're feeling pain while swallowing. So that is the odynophagia. Let's say even GRD, even candida, they can lead to odynophagia if serious case actually. Now, speaking about the dysphagia, causes of dysphagia, is it normally a early symptom of GERD? That's my first question. Is it normally an early symptom of GERD? Answer is a no. It is usually a late symptom of GERD because at the end of GERD there can be cancer, but it is an early feature of a cancer. Okay, it can be early feature of a cancer. Example, the situation like stricture and situation like tumor, these two conditions, dysphagia is a very classic example. We can also write it down in that way. We can also write it down in that way that in case of GERD as a complication. We can also write it down in that way as a GERD complication. Clear, everyone? As a late feature, as a red flag feature. So that's dysphagia for it. So these are the dysphagia mostly for the solid. Am I right? So this brings us to the point for dysphagia, the term, there can be dysphagia for solid. So solid example, cancer, solid example, structure. There can be one, two more for that, but these two are more popular in the exam. All right. Also GERD, late feature actually. Eventually that can be cancer. And there's it dysphagia to liquid first. So in which case do you think dysphagia to liquid? That is the achalasia. So in achalasia cases, dysphagia to liquid and some of the other functional conditions, right? Like myasthenia, like stroke, those cases there can be dysphagia to liquid things first actually. Okay, some systematic conditions. So mainly we'll remember dysphagia to for solid, for cancer, for stricture, and late cases of CRD as a complication. Okay, and dysphagia to liquid achalasia. Is it clear to everyone? This been tested in exam. This is very popular for the exam. This information we really really need it. Okay, now we are entering into this dysphagia chapter. A few lot of points given. A lot of points often needed in MC part 2 as well. Don't forget, you need to ask a lot of questions. That's why every chapter in the beginning they give you a lot of question type of thing. Okay. So next coming thing in the lineup is esophageal cancer, then we will see the achalasia actually, because we are talking about the GERD and the GERD, then the Barrett's and the cancer. So they're quite interrelated. Now, can you tell me about some of the features related to esophageal cancer? One thing you know, basic, this is esophageal area, so its dysphagia would be common, right? Other than that, the classic symptoms of cancers like weight loss, anorexia, these things, immunity loss, they're consistently having some infections, right? So those will be quite a common. Now, if you check the background, is it common that there would be like smoking history? Would you expect? Yeah, you can say a bit rapid dysphagia, yes, or it is faster. I mean, progress. I mean, quickly it's getting bad. Yeah. So you can see few points are given here, as you all can see. First, is it a bad cancer? Like this, all cancers are bad, but is it a bad or worse cancer? It's a worse cancer. This esophageal cancer, pancreatic cancer, worst cancer ever. Yeah. Survival poor. Survival rate is not good. Anyways, weight loss, then hoarseness is a very important feature. Dysphagia can be an important feature. Right. So these things can be important. So can be associated with GIT, can be associated with smoking, can be associated with even bad esophagus. Now, how to confirm esophageal cancer? Very simple thing. Like first, you can definitely do barium, this and that to rule out other things. But esophageal cases, mostly your diagnosis confirmed by. They also mentioned barium, but barium is not for confirmation, but to get idea, it's not that disease. But when you do the endoscopy, basically your diagnosis is confirmed. Clear, everyone? Next point that is coming, so is a type of the cancers of the esophagus. Already I highlighted earlier, upper two-third, lower one-third. Upper two-third is squamous cell cancer, lower one-third is adenocarcinoma. Remember, guys? So here is that line is given as well. Please highlight this. Upper two-third and adeno is like lower one-third. Adenocarcinoma associated with Barrett's. All right. Quick question, page number 460. Yes, the next thing that is important is surgery is required. Let's say it depends on the staging and the grading. Let's say it is a stage 2A, stage 2A, not metastasized. Can we do the surgery? Yes. But yet, this is an area where the surgeons don't really like actually. Okay, it depends on a lot of things, which structures are involved or not involved. Yeah, so that's very, very important actually. We're currently at page number 460. Yes, in ninth edition we're using. Okay, so here we go. Like the first priority for any cancer is surgery. First, um, for any cancer, if it is applicable, if it is the early stage, and if surgery is doable, like preserving the nerves, preserving the other structures, there is always surgery, but sometimes always surgery is not possible. Then we also have the backup plan like strong chemotherapy, radiotherapy, these things we also do. Sometimes, we don't have any choice. Sometimes we just do the surgery just to relieve some pain. Sometimes if you see this word like palliative surgery, it means we do it. Is it a curative surgery, palliative surgery? That's the interesting question. Is palliative that word is a curative? No, palliative to relieve the patient because esophageal cancer is increasing, it's hurting. So you just make some space. For liver cases, we also do that. We have this palliative surgery. We make some space. We give the patient little relief. Okay, so that's the thing. Is it clear for the esophageal cancer, guys? If you go to our SMA note, you will also find note regarding this, the esophageal cancer. Again, if I add three, four main points, esophageal cancer, that is one of the cancer with worse prognosis. This will be presented with dysphagia, hoarseness, and typical cancer symptoms. It also has good connection with GERD via this Barrett's. Yeah, Barrett's esophagus has an adenocarcinoma, but esophageal cancer upper two-third is squamous, and squamous is more common. This is another important exam question. Which of the following which cancer is common in case of esophageal cancer? Answer is squamous cell carcinoma. Now, little bit twist. In Australia, which cancer is most common? Squamous cell carcinoma, adenocarcinoma. This is tricky. So, but adeno in Australia. That's interesting. This one you have to remember. In the whole world, generally squamous. In Australia, adeno. So very tricky one, guys. Okay, very tricky. Clear about the esophageal cancer, everyone? We learn about symptom, we learn about association, we learn about types, we learn about the treatments. All right. Whole world squamous. In Australia, adeno common. Okay. If you are clear up to this part, then coming to the achalasia. If you remember in the first class, I mentioned few points. If we can add some adjectives into this one, what would be some of the key lines to remember for achalasia? All right, starting with that one. Here we go. I'm giving you 10 seconds to add one particular or two particular word you want to describe this achalasia from the exam point of view. Yes, come on, guys. Very important, someone mentioned. I really like it. Adenocarcinoma. Yes, dysphagia to liquid, someone mentioned, but even better is no heartburn. Because with that word, with that negative history, you are differentiating with GERD. Well done, dear doctors. So we are also expecting dysphagia, but dysphagia to liquid. It is a esophageal motility disorder. If you want to explain what about disease, it is a motility disorder, dysphagia to liquid first. Over the time, liquid and solid, and no heartburn. Very important. No heartburn. All right. So no heartburn, but there still discomfort and this and that. Diagnosis confirmed by barium sallow. Like most esophageal this is another important thing. As like the last day rheumatology, you see most of the rheumatological doctors started with CBC, ESR, C-reactive protein, right? That's a very basic and often X-ray, some of the basic tests. But in esophageal cases, often the basic test is barium. Did you get this information already? Yes. Now, how to confirm? Previously ZRD case it was 24-hour pH, and this time it is manometry. Am I right? Manometry. Heard this name? I'm sure it is. Now talking about some of the treatments related to this achalasia. What are some of the treatment related to achalasia? Yeah, initially it has always been conservative. Uh, you can add this thing like a CCB as a drug. CCB, calcium channel blocker as a drug actually. Right. Now, a few more other things because it is a mm, tight sphincter. Achalasia, you are expecting relaxed sphincter or tight sphincter. Now, this is another interesting achalasia cases. Let me draw this is for you. I'll be taking less time, I promise. All right. So this time, let's say very small. So it's tight. If it is tight, so no heartburn. Okay. And now if we are So sign symptoms already mentioned. Now, if we talk about the investigation would be barium as an initial and confirmatory as a manometry. Yes. Now, we talked about the treatment. Initially, it is been conservative. Now, conservative is a lifestyle, always. And as a drug, you can give the CCB, that is the number one. Then you can give the, there's another option called toxin, botulinum toxin. But one of the major treatment is some of the dilator. Okay, because it is tied. So if you give something like a to dilate, so as a dilator, it's often known as by the inventor's name, Heller's dilator actually. So Heller's dilator will make it expand dilator. And last one is you know what it is? It is a surgery. MC will often ask you which one of the following is the most effective treatment. Effective, always remember, this is a trick which is done in MC often. Which one is the most effective if they ask things like that? That is the surgery. What is the most effective? That is the surgery. Not only in these cases, many other cases, surgery is being the number one as a most effective. There can be a few exceptions which we will discuss in future. But this is the lineup for the achalasia. Are we clear about the achalasia? And achalasia cases, it is a motility type of disorder. If I draw, these layers in GIT, there's a layer mucosa, and that is called the submucosa. In submucosa, there is a thing called myenteric plexus. Have you heard this name before? Yes, I'm sure you do. This myenteric plexus, this thing is absent or been damaged, whatever the way. So if this is related to peristalsis, so thus peristalsis movement will not happen in case of achalasia. Now, even more clear, we went into a little bit more deep down why the movement is not happening because of lack of the myenteric plexus actually. Summary thing I think already we discussed. Let's get back to the next one. Everything clear, guys? Three esophageal condition just now we learned. Here's some certain drug names given. It's a nice to know like doxycycline that can cause esophagitis. Also, if you remember last day the drug name came, if you remember, alendronate that can also lead to esophageal irritation, right? Alendronate, bisphosphonate can also lead to. So stop the offending drug that is often the first line if it is causing it. Now, that's not the main thing. That's less important, the drug causing of esophagitis. Next one, have you ever seen in the prescription or have you ever prescribed things like that in that way that the professors often it is written something globus. They didn't write the word globus hystericus, but they just give a triangle and often the patient complains that I feel like something is stuck in my throat. Something they feel like all the time going to the doctor. So doctors sometimes they address it as a globus. There's no such real fish bone, but the feeling is kind of real actually. They actually feel it. Okay. Even though fish bone or I mean it's often can be because of even allergy or anything. All right. Here's the thing given in like infective esophagitis, it can happen because of candida and also herpes. Okay, great. So two nice to know topics. Globus, drug induced. Even if you forgot, it's okay. Now let's get into one that is more and more important for us. Ready with this one, guys? Everyone? Okay. Now, if you want to like describe this one, I'll take the screen. I'll just take this screen. I'll show you this thing from the SMA note. But if you want to explain this particular condition, which is uh, eosinophilic esophagitis, how would you like to explain eosinophilic esophagitis? I'll just bring that SMA note for you. Okay. Resharing screen again. Okay, M for medicine. Then you see the GIT. There is ZERD node, achalasia node, inflammatory bowel disease, lower GIT. Right. Lots of type of nodes are available. Okay. Certain points have been mentioned by the doctors. I'm just taking a second to show you a special type of node. Okay. Yes, we are ready. So that's the John cut piece. You can understand. First of all, allergic type of condition. By name, it's there. So eosinophilic esophagitis. So eventually, you find dysphagia. But allergic conditions, so IgE level elevated. These are few points. They can have issues with specific type of food. I repeat. So this is related to food actually, right? Now, because it's an allergic condition, eventually what you can do is stop the offending agent. Those food they have problem need to stop, and you can go with steroid. And there's another option like barium solo as a test, and you can also do the endoscopy. Here is a special line which is not given in John Muktak, but in the exam they can ask you, which is upper GIT endoscopy showing multiple constrictions. I repeat, upper GIT endoscopy showing multiple constrictions. Okay, these are few points. I'll show you same thing. So one more thing. Eosinophilic, sometimes also written in some places as a EOE. So some summary things. First of all, in the question, it will be given often food related problem, often given as a food related things like a cow milk, soy, wheat, or food allergy is not an uncommon thing. Please consider that. It can affect the milk and child and the adult both. Other allergies can be interrelated that if eosinophilic esophagitis, they can previously have asthma problem. Um, if you do blood test, Ig level elevated. If you do endoscopy, there will be eosinophilic infiltrations. And when you stop the food, there will be a period of like 72 hours. When you stop the food, the symptoms will start to wash away. All right. And as a treatment, like you see, IM Bascopan and solo topical corticosteroid fluticasone. This can be used. So these are the some of the important thing actually. Not related. See, every food they can have individual problems and this and that actually. Nut can have a generalized allergy. 40% among the food, 40% is often nuts. Okay, so that's the thing, but that's the more generalized. But for particular for esophagus is to remember is milk because it goes through the esophagus. That area often leave it a bit more inflamed. Yeah, so more. correlation with the milk type of food with the esophagus. Clear, my dear? Coming to this one, yes. All right. So, are we clear about the this particular eosinophilic esophagitis, guys? Please comment in the comment section. The next coming topics are coming up. Yeah, our this Mallory ways and you know the remaining. Just taking a minute from the dear doctors. Is JT feeling too difficult, or I mean, is it doable, dear doctors? Doable, right? Excellent. Sharing the screen again. Here we go. Eosinophilic esophagitis. Eosinophilic esophagitis. For you, let me highlight few points. Inflammatory condition. You can also write allergic condition. There can be dysphagia. It's often allergic. You see, cow milk. They have mentioned IgE level elevated. So refer to gastroscopy means endoscopy. Endoscopy will show eosinophilic infiltrations actually. One thing you can do is stop the offending agent for 72 hours. Like let's say the milk is the main problem, you find an alternative to the milk and you suddenly see the person will feeling better. The six food elimination technique, the food, whey, soy, egg, seafood, and also the peanuts. So these general things to be stopped. These are very common ones actually causing this thing to happen. Yeah. Right. So when the issue happened, steroid and the Buscopan. In the meanwhile, you can also, because inflammatory, so PPI can be given, but that's not the mainstay. Are we clear about the eosinophilic esophagitis, guys? Did you mark your John Muttak already? I'm sure you do. Okay. We'll start next some of the stomach related problem, but there are a few more things to I need to address. Let's say Boer habs, which has not been discussed, first of all, in John Muttak. Okay, let me show you something. This one is separate, may not be in the SMA note. So this one, maybe you can take a picture. It's a differentiating table, Mallory ways and the Boer habs actually. So only for this chart, I recommend you to take a picture. Yeah, which is an uncommon one, but Boer habs has been tested. Cool. Which one is more dangerous? First of all, both of them are dangerous. Both of them can be associated with bleeding issues. Bleeding issues. Starting with mucosal membrane tear, full thickness esophageal wall rupture. So, what do you think? Which one is more dangerous? Certainly, the one full thickness rupture will bleed out to the death. Very high chances. Which one can be interrelated with a pneumothorax type of issues? Is another important correlation. Which one can have pneumothorax issues? The answer is a Boer halves actually again. The answer is a Boer halves again. So that's even more dangerous. Both of them are dangerous, but Boer halves even more dangerous. Both of them has a common history. The last night they do a lot eating or a binge drinking, or a few hours ago, there will be binge drinking. So much pressure on the esophagus and esophagus rupture. Now we have a Eid coming up, so I don't want to scare you guys. So I think some of you can eat in limits. I think so. Otherwise, there are some dangerous situations. All right. So this is about the bowel halves in short. So there'll be rupture, and rupture can leads to chest pain like feeling, and the patient gets into the shock. Yeah. So that's common for the bowel halves actually. I'll show you a question perhaps that might help you. 40 years after a conference meal. Remember those days we used to have a big buffet meal in, especially during intern days, and like some of the drug companies, they organize it. Sometimes we used to call our friends, okay, this department is having a conference and they have so much meal. Let me know in the comment section if you have done things like that, informing a friend that there is a free food available actually. All right. I even have seen a friend, he was like taking 4 or 5 plates, and he was carrying a laxative type of thing. Actually, I don't know what it was, hajmi, or is it a laxative? I don't know what. Because in between the food, he was going to toilet, we found. And then again came back, then he started eating. He was like a huge guy, by the way. So, anyways, nostalgic feeling regarding those days. This is something about the doctors. At some point, because different people are coming from different social background, I think, which is different. But there's a funny quote like, at some point, because of lack of money, you can't really eat whatever you want. But there will be a point that will come for doctors. You'll have so much money, but you can't eat again. Okay. I hope you all understood that, at some certain point, it takes so much time for you to pass these post graduations. And then, at time, it becomes like 45, 50. And then, the other health issues, cholesterol, spikes up. Then, even though you have all money, but, going to five-star, eating those buffet, you will not want, considering health. And that interest also goes away. I mean, a different one is a different age group here attending the class. But maybe those of you are probably like up to like 35 age group now. You will, we don't like feel in that way now actually, like about, okay, as like a 3 4 plates, we don't think actually. You more focus on now fitness and all these things now actually. Yes. I mean, eat in a limit. Cheat days are okay. So that's fine actually. Yeah, but eat in a limit. Even in the cheat days, eat in a limit actually. I mean, eat in breaks actually. Eat in breaks means, okay, you eat something now, and then maybe after 2 hours, 3 hours, then you eat something. Suddenly eating a lot, sugar spikes up. I mean, you all are doctors, you all know this actually, and there's a lot of other chances of this, boil halves, obstruction, many other things, especially meat type of things. Very be careful about eating. Anyways, a 40 year after a conference meal, now forced vomiting. This is another key thing. This is another key thing for this boil halves condition, forced vomiting, and there's sudden chest pain and heart feature, heart attack like feature, or he also has a heart disease in past, so you can be confused with heart attack type of thing. After resuscitation, ABC is done. What is the next important step? Now you can also think about going towards checking the heart condition, because he had heart things, but this diagnosis with this X-ray is interesting. This X-ray, if you see the trachea, is it centrally placed or is it bit shifted? It's bit shifted. So here's the thing, this is a Boyer Haps actually. It's nothing but Boyer Haps. So what you do, we do an X-ray to see this particular things. So lateral chest X-ray. So this X-ray we need to do. Later you can do the CT scan if you feel like surgery is needed. IV fluid, antibiotic, admission to intensive care, and eventually surgery is required. Most cases, I think definitely surgery is needed because it's a full thickness tear. And you can understand if esophagus has full thickness tear, you definitely need surgery. Clear, everyone? Full thickness tear, definitely you need a surgery. Coming to this slide again, I'm holding here for uh, 15 more seconds. Those didn't take the picture, uh, please take a picture. So that's the Boerhaav's part actually. Boerhaav's is an emergency. Last night, a lot drinking, and now forceful vomiting, and so much pressure that full thickness esophageal wall is teared up. Patient's vitally unstable, including chest pain. He's almost dying, lack of breath. So you eventually nothing per oral, and you do the surgeries. You come to the Mallory waist, some partial tear, and it is usually less severe. It also has the vomiting features, but inside there will be bleeding. So blood vomiting or melena, these will be the features actually. But this can be managed conservatively, and this usually managing conservatively, this Boerhaave is difficult, guys. When you are done taking pictures, taking notes, let me know. We'll proceed from here. That's the end of the esophageal things, actually. Another thing is esophagitis, you can understand. I mean, it's a broad term, esophagitis. It's because of drug, it's because of GERD, it's because of any pathological changes. There can be esophagitis. Okay. So, but that's a term, actually. Another thing, lower end of the esophagus can bleed. That can lead to variceal bleeding, which is a not a part of here to discuss. Yeah. Okay. All right. So I believe we have done successfully this part. If you let me know, dear doctors, my talented doctors, ZRD, achalasia, Barrett's, we done together. Then we did this cancer. Then we came to allergic condition, Mallory and Boerhaav's, and also we finish these things. All good, clear, clear conception. All right. Next thing that is coming up, piling up in this list. If anyone joined late, initially we give you guidance. You need to do theory, recall question bank and forums. Shahriar's MC guideline is a fantastic forum. You can use the hashtag GIT and search previous lot of questions. This group is created in 2016, so it's been 10 years of this group. Yes. All right. Yeah, it the previous question answer was lateral X-ray. That was a Boerhaave scenario given, and the answer was X-ray, lateral X-ray. All right. And finishing with the mock, we gone through the esophageal condition. Now coming piling up is it. Now tell me a few diseases which definitely we have to cover from the stomach area. Of course, starting with a few things. Peptic ulcer disease. What else, guys? Cancers. You can also say dyspepsia. It's a chapter as well. Non-ulcer dyspepsia, another term. I'm talking this one, then that we can also say bleeding. Under the peptic ulcer, gastric ulcer, duodenal ulcer, all ulcers, dyspepsia, cancers, yeah, yeah, drug-induced ulcers, gastritis, yeah, PAS, don't forget that, pyloric stenosis, yeah, Zollinger-Ellison syndrome, yeah, that is important. Yes, all right. So those are some of the stomach-related things. We'll hit it very shortly. Pseudomembranous colitis, I'd like to put it in, I mean, yeah, for intestine, it is more to discuss. Okay, we'll come back to that one, but these are in general, I think, for the uh, stomach. Guys, would you like to take a break here, or should we finish the stomach things and then take a break actually? Yeah, esophagus was a little long because many diseases. Stomach would be less one, mainly peptic ulcer and cancer. Okay. So everyone, after coming back, we'll go through the stomach and then the intestine. Anorectal region is part of the surgical, so you don't have to worry here actually. All right. No worries, guys. See you soon. 10-minute break. It is for you. All right, everyone, let's get for the go for the break and come back after the break and we'll go for the remaining. Thank you. All right, everyone. So after the break, let's get started actually. Okay, so we were talking about this. If you remember, we have done with this esophageal condition. Now it's time for going with the stomach related things. And starting with this thing is a peptic ulcer disease actually, right? So guys, can you tell me which particular ulcer is more common actually? Which particular ulcer is most common? That's the first question, I think. Okay, keep going, guys. All right, so here's a little bamboo for guys, if you remember from the last day. Which ulcer is more common? That was the question. The answer is non-ulcer dyspepsia. All right, hope you enjoyed that. 40% of, ulcers, 40% of these situations are non-ulcer dyspepsia. Non-ulcer dyspepsia. Like most people does not have the classic ulcer. I mean, many people around us, they say, okay, I have discomfort, this, that, but it's not the classic ulcer. They have the non-ulcer dyspepsia mostly. Clear now? Now, coming to this thing, this is given in the SMN, so you don't have to worry. So duodenal ulcer, which is more common in between these two ulcers, but generally, if it is asked like which ulcer is more common or which is the number one cause of dyspepsia and this, that. So in that case, actually, non-ulcer dyspepsia is the right answer. Clear, everyone? Starting with a unique thing is better, actually. All right. Now, this particular duodenum, this particular area is a gastric, right? Another key question or spatial line or spatial addition line for this hunger pain. So duodenal ulcer, hunger pain. When you're in empty stomach, you feel pain. Gastric ulcer, when you eat, you feel pain. When you eat, you feel pain. That's interesting, right? So what case do you think will have a weight loss actually? The final answer is a gastric ulcer. Gastric ulcer will have weight loss issue. Why? Because when you eat, you feel pain, so you start eating less. Which case you feel is bleeding is a more predominant. So in both cases that you have bleeding, but one of them is more chances of lot bleeding. Answer is actually duodenal ulcer. Duodenal ulcer has like more chances of bleeding because the bleeding is from the gastroduodenal artery, so the bleeding is much more prominent. Whereas in gastric ulcer, perforation is more predominant. It doesn't mean that duodenal ulcer can't have perforation. They also do. It's just the ratio is a little bit more. So bleeding more in duodenal ulcer, perforation more common in gastric ulcer. I already mentioned this epigastric pain relieved by eating. So it means hunger pain. Epigastric pain exacerbated by eating actually. So you have pain in the epigastric region, right? Now, one more interesting thing, this ulcer or GERD, often, 40 or 50% cases of heart attack or heart attack like features ended up with simple gas problem, right? So these particular ones can be reason actually, non-ulcer dyspepsia, peptic ulcer disease, then of course the GERD, this all constitution also need to rule out if it is not a heart related issues. Okay. Very, very important for any ulcer is a lifestyle modification. Agreed? Yes. So, what is in the lifestyle modification? Avoid spicy food, junk food, and very importantly, avoid smoking because smoking affects the prostaglandin in the lining, right? Is it very important? Like, the risk factors, of course, and among the risk factors, of course, there is a smoking, but is it also true among the risk factors, there is a stress? And the bigger, another thing is a H. pylori. I like to highlight this line, and now our lecture will begin regarding this. So the H. pylori is something we need to break it down actually. So there are a lot of risk factors you can see in the John Murtagh family, smoking, stress, this, that, NSAIDs, of course, and of course this H. pylori. Now, H. pylori it is important to rule out. Now, can you rule it out by doing simple endoscopy? The answer is a no. We have a spatial test, and what is that spatial test name? That is the urea breath test, right? Urea breath test actually to make a diagnosis of H. pylori. To make a diagnosis of H. pylori. If you use also corticosteroid, is also high chance alcohol diet is all are some people do extreme diet, so that's also can be dangerous actually. So dyspepsia are more common, discomfort, epigastric pain, these are more common features actually. All right, so these are the thing. um, Endoscopy of the upper GIT is the investigation of choice. Okay, in some cases you do the barium because if it is a stomach ulcer or esophageal ulcer, whatever it is, you need to rule it out. Or barium can be done for esophageal area, barium can be done for stomach area as well. Now, very, very important to rule out from here is the H. pylori test or the urea breath test. Very important, rule it out by simple blood test. Okay. Even the ulcer, other than the irritation, pain, it also can cause a lot of other problems like perforation, bleeding, obstruction, anemia. Even it can lead to cancer, which also can lead to cancer. Gastric ulcer can lead to cancer in some cases. Okay. All right, so everyone. So, what are the treatments? So, if before going into anything next, okay, there's a thing given bleeding peptic ulcer. Before going to the treatment, please highlight this thing which is came in between. This ulcer can bleed as a complication. Some cases the bleeding can be very much severe and can be life-threatening. Am I right, guys? And that is titled as bleeding peptic ulcer, or you can say severe bleeding peptic ulcer. If it is a mild moderate, it will be just like a melena. But if it is a too much, it can be life-threatening. All right. So this particular drug you need to remember, this is very popular. Even this year it has been tested again. Injection adrenaline. I repeat, what is the immediate treatment in this case after resuscitation? Injection adrenaline. So please keep it in mind actually. So heater probe, I never found in the question, but injection adrenaline multiple times. Now here they talked about the general treatments of peptic ulcer. So here we go is the things like proton pump inhibitor is given for this particular week. Proton pump inhibitor is given for this particular weeks actually. Okay. Next coming is a therapy to eradicate H. pylori. Therapy to eradicate H. pylori. Are you familiar with the triple therapy? I'm sure you do. I'm sure you do. You are familiar with the first line therapy, the triple therapy. These are the triple therapy. Now, among the triple therapy, did you know this information? This metronidazole is a drug that often can be resistant. Did you know this information, guys? That metronidazole is a drug. So resistant to metronidazole is common. Even the clarithromycin is increasing. So, but uncommon with tetra or amoxicillin. So the alternative has been mentioned here. So there is a thing that comes like why the treatment failure is because of metronidazole resistant. Can it be a cause? Metronidazole resistant? Why your triple therapy is failing? Yes, very high chances. Metronidazole is a drug that is often given is like divided doses. Like even our mom used to give us in the when we were kids this metro thing, right? It's available actually always as a more like should not be used as over the counter, but in our countries it was so much over the counter actually. Now, this also can be so dangerous at some point. If all your medical treatment failed, you can also consider doing the surgeries as well actually. So surgical treatment usually not common, but all medical treatment fails, serious bleeding all the time, then you can consider that. Okay. Is this another separate diagnosis? NSAID induced peptic, NSAID induced ulcer. Yes, and in that particular case, basically you need to stop the offending agent. In that case, you need to basically do one thing, stop the offending agent. Please remember that. All right. Few more other things that this like. situation can happen like gastritis. Gastritis can be also because of H. pylori. Then this peptic ulcer disease, duodenal ulcer, gastric ulcer. Again, root cause can be H. pylori. Then there is a thing called like some of the antral condition that can be also because of this non-ulcer dyspepsia. Again, this can be cause maltoma. There's another condition that can be also because of H. pylori. So H. pylori can cause a lot of things, including the gastritis as well. Actually, we're talking about the stomach-related thing now. In the pipeline thing is coming up. Let me check if there is anything left. Yeah, today's esophagus. Now in the lineup is a stomach cancer. Stomach cancer. Now, can you guys give me some informations about stomach cancer? Guys, can you give me a little bit more information about the stomach cancer, guys? Before I bring something for you, can you give me some more information? All right. Stomach cancer, of course, weight loss can be an initial feature, very popular from the exam. Okay, since it's a cancer, stomach-related cancer can be deadly, by the way. Uh, in last 1 decade, stomach cancer or last 2 decades, stomach cancer, do you think increased or decreased? What do you think? Stomach cancer in last 1 decade increased or decreased in generally? Like say overall cancer decreased, overall cancer has been increased, which is very basic. But stomach cancer was in past was a kind of more actually. I mean, the ratio compared to the other state in race in that way, but generally the number of people increased in that way. You can say previously the number of people in this world, number of cancers used to happen. So comparatively, that one probably decreased, but generally numbers may be increased, but the ratios, yeah. Because people have been more careful about drug, people have been more careful about their diets. Yeah, but at the same time, some countries, I'm talking about some countries like our Asian countries. In our Asian, this belt, it's actually almost kind of the same, remains kind of the same actually. So probably it's increasing even more because of more junk food, whereas those European countries and the many others actually, they have been switched more to the more healthy diet actually. So in our countries versus those Western world are quite different guys actually. Um, when we read about stomach cancer for the very first time from big books, the Japan related studies used to come a lot, right? Is Japan is a country which has more stomach cancer or less stomach cancer? What do you think? Japan is a country which used to have more stomach cancer. Now they have a little changed it because of more, those raw food and things, that shown some connection, I mean, with the stomach cancers actually. So because they eat more raw, yeah, raw and smoked food. So that's one of the link has been shown that cancer has been a bit more in Japan actually. Stomach cancer particularly. Also understood one thing, genetic association is also plays an important part in cancer, isn't it, guys? Genetic things is quite, I think, the most important probably always because it is stomach related. So food has an important part to play actually. So those smoked food, processed food actually. One thing that is quite an universal, guys. Remember one thing: those canned food and the processed food highly cancerous. So if your babies, like let's say, even the babies are eating the chips from the Pringle packets or any others, any processed one is always highly chances actually. All right. See, chocolate is a different thing. I mean, but many other, so much high calorie food. Even long time chocolate is also not good. Sometimes anything is fine in the cheat days you can eat actually, but a lot of kids like let's say juice, they're eating a lot actually, the processed juice and this and that. So this can be quite a dangerous actually over the time. Now coming to this one about the risk factor, we have a mnemonic with a 5A. 5A, it presents like that, like anemia is one of the common, eclarohydria, then gastritis, adenomas, type A. These are some of the risk. These are some of the risk we have. Among the cancers, adeno is perhaps a little bit more early, aggressive local spread, and often it can be associated with H. pylori again. H. pylori you can see. All right. And the diffuse version may not be associated with H. pylori, but the intestinal version, yeah. So that's one of the things. Is it true that a stomach cancer related thing can be is there any association with left supraclavicular lymph node? Guys, I think we read this thing in the MBBS, like the stomach cancer and this left supraclavicular lymph node has that association. Yes, as a Trocheer sign. Well done, guys. Now coming back to John Murtha. Yeah. You often remain asymptomatic, dyspepsia, which is unresponsive, a situation which is not responding to treatment that to taken care of. Dysphagia can be presented, but it's a late sign. They can have anemia, they can have weight loss, often the early things. Here the things are given. The risk factors: high in salt and smoked food. That's why the Japanese, those food, early days Japanese foods were more affected actually. Yes. Uh, have you seen how the sushi has been processed? Is it a raw food? Sushi? And is some of the smokes are has been used? They have some sort of like firing thing, because to in order to add that layer, a torch type of thing, they also add those fire thing at the same time. So that raw thing at the same time that the fire thing, smoke thing, all of a sudden, I mean, see, slow heat. Is it good? Slow heat, guys. You are making a food and you make that food with a slow heat. Is it good for our tummy? Very good for our tummy. But in restaurants, what happened? They're in mood of making things so faster, so a lot of things with a very high temperature, so nutritional values goes down, and at the same time this risk being increased actually. So, and also salt and the testing salt at the same time, another dangerous thing actually. So next time when you go to any restaurant, I mean, we all love to eat, tell them if that's possible, please add less salt or less testing salt if that is possible. Another thing is like in my experience, I'm telling that mayonnaise thing. It felt like, oh, it's just a mayonnaise, um, 3-4 spoon of mayonnaise, what else happened? But 3-4 spoon of mayonnaise, check carefully, in ChatGPT and things, 3-4 like spoon of mayonnaise has a lot of things actually, sugar, this, that. Anyways, here we go. Like weakness, dyspepsia, weight loss, this is one thing. Loss of appetite, weight loss, color. So, anyways, and what we do is a upper GIT endoscopy. Upper GIT endoscopy and the biopsy. And if it's under the grades and stages, stage 1 and 2, of course, we try for the surgeries. Wherever possible, we try the surgery. Yeah. Good question. Is barbecue meat risk for stomach cancer? Yay. Quite a yes. Because see, it remains quite raw often. And yeah, that's the thing. Anything excess is not good, my dear. See, steak is a good food for. Do you believe like steak can be good food for diet? I mean, yeah. No, yes, actually, it is a yes. Steak is a good food for diet. But thing is, when we go for eating those steaks, is it the only steak we are eating, or uh, there is a huge amount of potato mixed with the butter and many salts? There is fries, right? Then there's another side dishes. So all together, now the things are different actually. Yes. All right. I think sometimes anything is not bad, but anything, try to avoid the white, bring the browns more. That's one of the tip. Try to add the brown ones more actually. Like, of course, you have to eat bread, you have to eat rice. Yeah. But since the word paratha is like so much put in oil, everyday eating can be dangerous actually. Yes. Air fryer, it's sometimes controversial, but it's a highly like too fast sometimes actually. As I said, the key is slow cooking, my dear. The key is slow cooking. Now, someone has a nice question. Do we need to know about staging of some cancers? Answer is a yes. Okay, like example, prostate cancer. You need to know the staging. Those cancer will be required to know the detailed staging. I will teach you those things, my dear. Okay. Example, prostate cancer. You need to know all the details. Ovarian cancer. You need to know all the details. Yes. Okay, so surgical excision and the stomach cancer is ended here actually. Summary thing about stomach cancer, a patient presented with recent weight loss and he also feels dyspepsia. And this dyspepsia is not responding with proton pump inhibitor. See, weight loss and the person having dyspepsia which is not responding well to the proton pump inhibitor for certain amount of time. You probably also do some other test and H. pylori positive, this, that. Now the patient is keep losing more weight and supracortical lymph node is positive on palpation. We are talking about stomach cancer in this case actually. So what we plan immediately is going for a surgery if not metastasis here. This brings us to the last part, that stomach cancer can metastasis to the which particular parts. One is a left supracortical lymph node, but what else the other parts actually? One you should know, I think from MBBS. Sister Mary Joseph, if you remember. Yes, well done. So, I mean, of course, the lung, liver, bigger organs, but the Sister Mary Joseph, that's like, your, that ovarian one. Ovarian one. Remember that one? Sister Mary Joseph, yeah. Yeah, great. Well done, guys. Okay, coming to this one. So, peptic ulcer disease. We discussed non-ulcer dyspepsia. So, one of the commonest one, the generalized cause of dyspepsia. And some of the drugs like NSAIDs, corticosteroid, these are the drugs actually. And now I'll bring you to the point about a few of the other things. That is the Zollinger-Ellison syndrome. Okay, I will make it bigger, but before I make it bigger, can you tell me some more points? Do you like, guys? I try to give some clinical ideas first before we proceed. So first of all, what kind of disease is that? First of all, what kind of it's a condition related to stomach area. Now, the next thing, what kind of stomach area is this? Is this a just a ulcer problem or is that a cancer related problem as well? It's a ulcer and cancer related problem at the same time. Is it a one ulcer or is it a multiple ulcer? It's a multiple ulcer related problem. So when you do endoscopy, you'll see so many ulcers and you'll be surprised why so many ulcers. Now, let's go deep down to see why there is so many ulcers. Here are a few key points for you. Solinzer, Elsinzer, it is given in our SMA note first of all. So you can find it, medicine GIT, Solinzer, Ellison. So increased gastritis. Number one, Zollinger-Ellison syndrome has multiple ulcer. Did you know this information? One of our gastric related, one of the hormone is gastrin. I repeat my word. Is gastrin is related to our gut, motility, and all this thing? I'm sure your answer is a yes. Did you know gastrin is released from which part? Answer: the parietal cell of the stomach. Okay, now let's go and see this part. So why there is a multiple ulcer? That was the question. There is a gastrinoma, so means huge amount of gastrin is produced. The gastrin comes and stimulates the parietal cell of the stomach. Stimulating the parietal cell, it releases more HCl. Now, is this more HCl is good? Not really. More HCl could not be handled by the stomach lining, and eventually there will be like imagine multiple missiles. It's like that. So there will be multiple ulcer. Is it clear, everyone, why there is multiple ulcer? So here is a summary thing, as you all can see. Gastrinoma, more gastrin, stimulating parietal cell, more HCl, more ulcer. Quick question, is this situation controlled with proton pump inhibitor? Because that is how it is given up in the exam. Is this thing controlled with proton pump inhibitor? Answer is a no. It's huge amount. Huge amount is produced. So no matter you give the proton pump inhibitor 20 or 40, the main complaint the patient will tell, I mean, doctor, you are giving me this anti-ulcer drug, it's not working for me. And why it would work with so much gastrin and so much acidity. So this is a condition, so much acidity because of a tumor gastrin. All right. So here is the summary lines. Too much gastrin is stimulating parietal cell, so many ulcers. And now if so much acidity, so much gastrin is produced, what is the function of gastrin? Can I say it's one of the thing is help releasing HCl, and eventually the gastric motility. Guys, do you agree? Gastrin is related to motility. Now you have so much gastrin. Now there will be so much mobility. What will happen if your gut is dancing? So we can say this thing, it's like a uh, dancing gut, right? There's so much gastrin. Eventually diarrhea. This line needs to go slowly, right? Otherwise, there will be diarrhea. And this diarrhea, you see this picture? The patient is on toilet, there's a diarrhea. Now, this gastrinoma and this zolderism is related to MEN1 association. We'll talk about this thing someday in the endocrinology, MEN1 association, MEN2 association, and there's another thing called MEN3 association. All right, it's like if you have cancer in one part, you can have cancer in another part. Like main one, you can have cancer in this area. You can also have chance of cancer in pituitary area, parathyroid area. All right. So this is the Zollinger-Ellison syndrome. Are you expecting heartburn? Yes. Are you expecting weight loss? It's a yes. So heartburn, weight loss, multiple ulcer, maldigestion, diarrhea. Yes. So, therapy of choice for Zollinger-Ellison syndrome is yes. So eventually you need good treatment. So mainly we'll give definitely proton pump inhibitor, but you also need to uh, treat the root cause, like chemotherapy and the proton pump inhibitor are the treatment. Chemotherapy or surgical removal of that particular thing. Remove the cancer, mainly remove the cancer by surgery or chemo, and proton pump inhibitor. Is it clear so far, everyone? Zollinger-Ellison syndrome. Too much gastrin. We don't need the regimen of chemotherapy for the AMC. If there is any specific disease will require for, let's say, multiple myeloma, we need to know the regimens. Okay, so some specific cases I will tell you actually. All right. Diagnosis by endoscopy, my dear. We do the endoscopy. We also do the gastrin, check the gastrin level. We also check the bow-mow ratio. The prognosis is not that good, my dear. Okay. So everyone, let's come and see again. Peptic ulcer, dyspepsia, non-ulcer dyspepsia. Then, yeah. So guys, pyloric stenosis is mostly it's like related to projectile vomiting. It's one of the differentiating very important with the GERD. Usually we read pyloric stenosis in pediatrics. It's a pediatric condition. Pyloric stenosis is associated with projectile vomiting. So it's like a pylorus part of the stomach, which is stenosed. So there will be vomiting, which will be projectile vomiting, and it will be non-bilious vomiting. So first thing first, you need to resuscitate the patient, nothing per oral, and you probably prepare for a surgery in that case actually. Okay, in pyloric stenosis actually. All right. Okay, so we're not going details for the pyloric stenosis. Neither those thing is discussed here in adult version, but in pediatric, I'll teach you that particular part. That's the end of the stomach part. I think so, guys. That's the end of the stomach part. Now it's time to go into the intestinal part. Am I right, guys? So peptic ulcer done, cancer done, non-ulcer, drug induced, zolinzolizum, these are done. Now, in intestine cases, what are the intestinal things we need to discuss here, guys? Inflammatory, very, very important. Inflammatory bowel disease, inflammatory bowel syndrome, intestinal cancer, but even though part of the surgery mode, you have to consider is it a medicine case or surgical case as well. Appendicitis, I'm afraid, a little surgical case actually. So IBD, IBS is mainly. Even I know obstruction is a very popular condition, popular thing for the exam, but we learn more for the in the surgery. Bleeding things are coming up here, lower GI bleedings. Yeah, IBD includes the ulcerative colitis and the Crohn's disease. Yeah, colon cancer, even the part of surgery. Yeah. Now let's come and see. I mean, also before going into that one, I mean, we also need to consider few more other things like is diarrhea is a part of the intestinal thing? Of course, it is actually, it's a medicine case. So page number 418, diarrhea related, you know, things are given like in general causes of diarrhea, acute diarrhea, chronic diarrhea. Actually, diarrhea for longer time, of course, chronic diarrhea, and diarrhea less than 3 days is like acute diarrhea, right? Right. And in case of chronic diarrhea, uh, you need to rule out the important causes. You also need to know about Giardia. Giardia, by the way, popular in the AMC exam actually. Right. Is followed by this one. Some red flags given. Important one of the thing is a pseudo member. See, there can be so many causes of diarrhea. It can be infective cause, it can be non-infective cause, it can be drug cause. All right. So here is a list of drug given. This drugs can also lead to diarrhea. Among them, you need to remember for exam is the colchicine. Last year, I think we found that one, this colchicine. Colchicine induced diarrhea is popular in the exam. But there's some other condition that can also lead to diarrhea too. You need to keep that one in mind. All right. There's another pattern of diarrhea that can be you're giving an antibiotic for a better cause, but the antibiotic can lead to diarrhea. Example, the antibiotic is given for an ear infection in a kid, like a amoxicillin, and that particular antibiotic can lead to eventually diarrhea, which is known as the antibiotic associated diarrhea or pseudomembranous colitis. Are you familiar with this condition? Yes. So pseudomembranous colitis, they often have watery diarrhea, page number 421, 421. And it happens within 2 days. This duration is important. Like within 2 days of taking antibiotic, it starts and often the custom differentially toxin. And because of this develops, that's why there is diarrhea. Now, what to do first? First thing first is antibiotic. Then you give the metronidazole. Some cases metronidazole may not work. Then you can give vancomycin. Then you can give vancomycin. I'm holding here if you can check. Please let me know if it is clear actually. C is the offending agent. This kind of thing you will find a lot in the exam. C is the offending agent. Then metro, then vanco. Yes. Is another name. Fidaxomycin. Speaking about diarrhea, some diarrheas are very fast in responding, especially, did you know this information? Staph and the bacillus, it is often related to food poisoning and very fast food poisoning. Actually, staph, bacillus, salmonella, these things are very fast in terms of causing the diarrhea or the classic food poisoning. So this intubation period can be important, like very short. Did you know this information? Chicken needed to be processed very well. Otherwise, chicken or poultry related anything can be very dangerous in terms of spreading the salmonella. So chicken, salmonella, marinated chicken, if you are keeping in the fridge and if you don't prepare it well, again, salmonella. You're trying to make a chicken soup and the chicken is too small and you don't process the chicken well. You can again, I mean, you're trying to help a patient, but you're giving them salmonella, right? All right. A few things given, these are not been tested except for longback puffer fish poisoning. Heard this name? That's a nice to know. You can just Google it. Puffer fish poisoning, actually. Okay. The remaining, I haven't seen much. Fawabin G6PD deficiency, I haven't seen it in last 5, 6 years. One question given, these questions are mostly for the other purpose. In general, investigation related to diarrhea, we all know it. Normally, it's a blood test, stool test, and some cases, if it's a chronic diarrhea, some antibodies. So, blood test, stool test, and also some of them are antibody test, actually, like ruling out celiac disease, let's say, for example. Yeah, this can be important. We also need to rule out if the diarrhea by any chance because of any malabsorption. Again, example, cystic fibrosis. In cystic fibrosis cases, we do the sweat chloride test. Cystic fibrosis, we'll learn, it's an important topic, we'll learn more in the pediatric actually. As the time progresses, you can do more bigger tests like endoscopy, radiology, if you cannot rule out the other things, ultrasound. Yes. Major problem of diarrhea, is electrolyte imbalance actually, and electrolyte imbalance can affect the heart as well. That is one of the reasons you have to be careful regarding this. Okay. His few diagnostic triads for diarrhea has been given. All right. We'll bring this part again in case of pediatrics, but here is few things. Abdominal pain, fever, vomiting, classic gastroenteritis. You need to give a good drug. If it's a chronic one, can be Crohn's disease, offensive bulky stool, malabsorption, right? Celiac disease can remain asymptomatic, initially fatigue and weight loss, and some vitamin deficiencies, and intolerance to particular type of food, actually. Okay, we're coming to that part shortly, so no worries. Another one, pseudomembranous colitis, diarrhea, cramp, distension. But in main exam, they will tell you also laboratory findings, this and that. So, anyways, you check this box. Now, coming topic is a malabsorption. Now, coming topic is a malabsorption. Did you know this information? Malabsorption cases, the stool, the word is offensive as well. The stool found on the toilet is quite greasy, floating, and very smelly. Yeah, of course, this is malabsorption because vitamin A, D, E, K is involved here, the fat soluble vitamins actually. So more fat on the toilet. So that's how bulky, pale, offensive, greasy stool. All right. So that's bringing us to the point. Absorption. Malabsorption can be a lot of way pancreatic, celiac, and many other deficiency cases actually. Among them, celiac is very important. Celiac is more popular in pediatrics, but we also discuss celiac here. Now, tell me few information about the celiac, guys. Tell me few information about the celiac disease. Okay, we haven't drawn in a while, so let's try to draw again. Let's take a piece. Normally, this is normal. Now, if you have a situation where it looks more like a flattened villi, normal villi, flattened villi, normal villi, we're trying to talk about celiac disease. We can say a few things about celiac. This is autoimmune disease. It is related to, it is an intestinal disease. It is related to gut and it affects the villi because autoantibody has been produced against the villi. So your villi in the intestines are affected. Villi are normally function for the villi is absorption. So lack of absorption, there will be flattened villi. So there will be malabsorption, right? And eventually in his stool, there will be like the fat malabsorption sign, floaty stool, and this and that. First thing, what is written in John Murtagh about celiac disease, it often remain asymptomatic. Okay, many Australians are suffering with celiac disease actually. If you go to many restaurants, you will see a special thing, a special type of diet that is called the gluten-free diet. Now, when you eat gluten, that affects this villi a lot more. Okay, so the gluten is the issue. The gluten affects the villi a lot. Gluten-free diet, gluten-free milk, gluten-free this, gluten-free that. These are become a sign for the even five-star hotels like the gluten-free. So you can guess about the treatment. I mean, before talking about the investigation, treatment is, gluten-free uh, diet. Am I right, everyone? The treatment is gluten-free mainly. Great. So eventually there would be malabsorption, this, that. One more thing I want to talk about, it's a brow. Okay, so in celiac disease, there would be intolerance to brow type of food. What do you mean by the brow? Brow means barley, rye, oat, wheat. I repeat again, barley, rye, oat, wheat. Right? Let's say, yeah, pizza, pasta, you use the wheat. Yeah, a lot of food, oat, rye, barley. Yeah, not rice, rye, barley, and of course, barley is not so common, like Weetabix. Yeah, like a lot of babies' food are. So babies also have celiac disease a lot, actually. Maybe barley they're eating. Celiac. Yeah. So, anyways, so intolerance to brow. So gluten-free diet, you cannot keep any sort of brow food. There's another line I want to add as a treatment. If all fail, um, Dapsone can be a treatment. Coming to the more important part, that is the investigation. That is the investigation. Yeah, Horlicks also has barley. You're right. Horlick has all the things are mixed actually. Okay, sometimes difficult to digest. Horlicks, some cases. Anyways, Speaking about the investigation, what are the investigation of celiac disease? Any idea, any cases? The tests like anti-trans glutaminase test, anti-endomysial antibody test, right? But are these blood tests are the confirmatory? Not really. Those are some of those initials. How to confirm? Confirm by duodenal biopsy or small biopsy. So this is your confirmatory site. This is very, very popular in the exam. This is probably the most popular one in the exam. One, celiac comes as a diagnostic. Celiac often mixed with the cystic fibrosis. You have to make a diagnosis. All right. And they will ask you about investigation. They'll ask you about approach. They'll ask you about how to confirm. So confirm is small bowel biopsy or duodenal biopsy. They can also ask you about treatment, gluten-free diet. If last resort is a DAPSO. Main pathology, autoantibody when you give the food like this brow food or gluten containing food, it affects the villi and villi become flattened. So flattened villi cannot absorb good amount of food. So there will be eventually malabsorption. I hope I explained well, guys. I'm giving you 30 seconds to absorb this thing. Then I'll move to the next one. Other people, if you have documented the things, then you can have some idea, which is also used in leprosy. All right, so I think let's go to John Baba. Sometimes John Murtag we call John Baba. So you see, often it's mentioned. That's page number 400. Yes, and yeah. So here are a few lines. Gluten. You can write brow, celiac. Can happen any age, including children. So they have GIT symptom and non-GIT symptoms like tiredness. Often celiac disease they can present with only tiredness. As the time progresses, there will be more malabsorption. Malabsorption. It can run in the family. They also give a uh, in general causes of malabsorption. I mean, it can be other things, right? Not only celiac, it can be lactose problem, it can be many other problems. At the time, it can be a pancreatic problem, surgical problem, many things actually. Coming to this celiac, these are some of the clinical features, including tiredness is probably the number one to remember. Number one thing is the tiredness actually. Yes. All right. And you can see these tests. Some of the tests are given here. Transglutaminase antibody test. This is very, very important. And characteristics is a duodenal biopsy. So this is just to confirm. This is something to confirm. So far clear here, everyone. So it's a condition related to malabsorption. So they have a GIT symptoms and non-GIT symptoms at the same time. And you need to do few particular tests, some blood test, and you can see the duodenal biopsy to confirm the further test. It's a condition also has association. The associations are given there actually. You see primary biliary cirrhosis. This thing has been tested in past along with celiac as an association. Okay. Already discussed is gluten-free diet. That's the main treatment. Okay. So you see, avoid food containing gluten. That's the only thing they are saying. Forbidden foods here, standard bread, typical bread like pasta, pizzas, biscuits, all those containing gluten. Clear everyone now? I hope that's clear now. And that was our drawing, and I hope it's helpful. We also went to little pathophysiology because it's an important disease. All right. We also were discussing little gastroenteritis, but it's more detailing given here. It's more acute condition, and some of the classic bacteria, protozoal, can lead to gastroenteritis, the classic one. Any illness which is less than 10 days and very acute, a lot of episodes of diarrhea. Yeah, great. I'm not going into this one. This is like a MBBS topic, assessment of dehydration, mild, moderate, severe. Just check the severe ones well. And, and one more thing. This is a topic I will teach you in the pediatrics, toddlers diarrhea. Very small kids, 1 to 3 years particularly, they often have diarrhea because they pick up things and put in their mouth. So, toddlers diarrhea. Very important is a traveler's diarrhea, guys. I mean, do you know about traveler's diarrhea? I mean, someone went for traveling and eat whatever they like, and because of E. coli is common, and they get this diarrhea. That's the classic traveler's diarrhea. Yes. Last but not the least, acute diarrhea. Hydration is so important. If they're vomiting, symptomatic treatment and a good antibiotic, and rest your gut. Proper diet, rest your gut. Yeah. So at the this particular page, like 431 page, all you need to memorize is, let's say, Giardia treatment is Metro, Shigella treatment is Cipro, right? Again, Shigella, Cipro, if you see here also Cipro or Azithro, all right? MBS is Metro, typhoid, azithromycin nowadays, and also Cipro. Cholera, I mean, there was rice saline, and of course, you need an antibiotic, right? So the last page, the choice of antibiotic, you can give a title 431 page, the choices of antibiotic in different conditions. Is it clear, everyone? So diarrhea, assessment of diarrhea, yes. And some specific treatment of various specific microorganisms. Now coming to this one of the last segment, which is inflammatory bowel disease. Inflammatory bowel disease. I'm taking the screen just to bring the inflammatory bowel disease in front of you. How many points do you know about inflammatory bowel disease, guys? All right. So what inflammatory bowel disease, mostly it's related to, is it an acute or chronic condition? First, let's think start with in this way. Yeah. It's a chronic condition. It's related to bloody diarrhea. So it's also related to ulcer because ulcerative colitis, right? So it's of two types, inflammatory bowel disease, Crohn's disease, ulcerative colitis. They are chronic, they're complex condition. Is remission is common here. Remission, and it's going and coming back. Is it common? Going, coming back, going, coming back. Is it common? Like multiple sclerosis. In neurology, I'll teach you. That goes and come back. His prognosis is good? Not always, actually. I mean, it depends on how good is the treatment and what is the stage, actually. There's types of inflammatory bowel disease as well. All right. How can you make a diagnosis of inflammatory bowel disease? So someone comes with chronic diarrhea and also blood and mucus. Blood and mucus. So this is very classic for inflammatory bowel disease. You need to go through the detailed history and this, that. So blood, mucus, this, that. You need to go through the endoscopy. Am I right, guys? Endoscopy and the colonoscopy. So mainly that colonoscopy, and both we do, by the way. So then we'll get to see the gut. We'll get to see the gut. It can affect the whole gut, right? Yeah, it can affect the inflammatory bowel disease, can affect the whole gut. That's why endoscopy and colonoscopy together, but mainly it is the colonoscopy actually. So what we offer in this case aim to control the inflammation because inflammatory bowel disease, inflammatory drugs are very so sulfasalazine is one of the mainstay, And in order to stop the acute things, steroids are important. Agreed? In order to stop the acute, things, because autoimmune things are involved here as well. So you need to give the steroid as well, actually. So sulfasalazine mainstay. Sulfasalazine will prevent the disease progression. Please understand the line as like the last day. DMARD is prevent the disease progression. So same here. Sulfasalazine prevents disease progression, where the steroid, yeah, mesalazine as well, my dear. So, and yeah, so steroid, acute, yeah, inflammation suppression. That's most important. Now coming to little John Mortag, let's see what John Mortag has to say. Ulcerative colitis. More common in Western world, family history is important. Lack of fiber, guys, do eat enough fiber. If not, sometimes that isogula husk, you can keep it at your desk. Sometimes we all are drinking water. Along with drinking water, just add 1 or 2 spoon. Okay, we doctors are always force patients actually, and we have random duty. We forget to eat. Everyday diets are important. In everyday diet, there is some fiber is important. So isogula is a very good thing, guys. Okay, important tip for all of you. Now, coming to this one, so family history, low fiber, and recurrent attack of loose stool. So diarrhea and the mucus, blood and the mucus actually. All right. This is special line, area of friable mucosa. This line you need to memorize or add into your John Mortag, because I have seen this line given directly in the exam. So you can write this line here, area of friable mucosa. Okay, write this line near to 432 page. So main symptom is a bloody diarrhea. As you all can see, main symptoms bloody diarrhea. This can be other features, weight loss, because when they eat, they also feel bad. Those are the things. So you do colonoscopy and endoscopy to make a diagnosis. Yes, and recurrent attacks are very common in this case. Again, another thing, Crohn's disease. We're talking about Crohn's disease and ulcerative colitis together, and almost kind of same, both of them. But the Crohn's has a little different um, presentation. Ulcerative colitis, like, it's a lot of ulcers actually, ulcers, and also there are pseudopolyps you can see. Whereas Crohn's disease is so much inflammation that the whole thickness is affected. Now, what do you think? In which case do you think more complications like obstruction, stricture? Which one do you think? This is normal. This is ulcerative colitis. This is Crohn's actually. And Crohn's has all 4 layers of the mucosas are involved. So Crohn's is the culprit for complications. Crohn's for C. Crohn's for the complication. I remember, like, ulcerative colitis is one of the condition which is not linked to smoker. Non-smokers has less ulcerative colitis. Very important. I mean, very interesting, if not important, interesting information. Long back, I used to teach the MBBS students, so that time, those who smoke, I used to also tell them few things. And now, the day I mentioned that, this is a disease which is less common in smokers, those were the smoker in the classes. They were clapping actually. That like finally, sir, something for us. All right, so it's fun. Like, so there was like 2, 3 conditions. Another one is a Parkinson's disease, Lewy body. Yeah, so those are the another 1, 2 conditions, which is less common in smokers actually. All right. So it's just a fun effort actually. This one, I think the pictures are, I think, Davidson medicine. Yeah. Anyways, um, great. So normal Crohn's, ulcerative colitis. Yeah, this book picture is a John Motak. Yes. So Crohn's, you can see pain, diarrhea, fever. Summary note for you. This is something you need for MC directly. My dear, this note is already given, so don't worry at all. And yeah, so skipulation. There's another term, skipulation. One here, one here, one here. So Crohn's has a skipulation. Interesting, right, guys? Crohn's has a skipulation. Here's a special line for IBD. Initial treatment is sulfasalazine. This you have to remember, like bullets for the MC. Acute flare-up to reduce inflammation, corticosteroid. Refractory or failure case, azathioprine. All of them has tested in the exam. All right. So again, little short summary. Okay, those couldn't follow us. It's a chronic condition, inflammatory condition. Am I right? It has two versions, ulcerative and Crohn's disease. This is a condition chronic and relapsing is common. So it comes back again and again. All right. Mainstay of treatment is sulfasalazine, and you also need a long-time management plan. Patient not only required that therapy, but also emotional support. That how to live with the inflammatory bowel disease, because your bowel is a every day-to-day thing, right? And so every day, if it's a painful, bloods are going, mucus are going, so it hurts. So ulcerative colitis, so recurrent diarrhea and also pain, area of friable mucosa, these are common. If ulcerative colitis, even chances of cancer risk is also high. Crohn's disease almost similar, again blood mucus. Yeah. Medicine, diarrhea, GIT, inflammatory bowel disease, you'll find it. Keep searching, later you will find it. Stipulation. Now coming to the last part, you can go to medicine GIT and you'll find it. Actually, do it later. You don't need to do that right now. Okay. Again, you see ulcerative colitis and the Crohn's actually. Interesting point. Ulcerative colitis, mucosa, submucosa, Crohn's, transmolar, all four layer involved. That is one of the reason. This one has stricture, fistula, and some of the other complications. Whereas ulcerative colitis has ulcer and the pseudopolyps. Okay, so GIT features and the extra GIT features are also documented here actually for both of these conditions, like bleeding and diarrhea and pain. Other than that, both of them have extra GIT feature. You see, extra GIT feature, extra GIT feature. Like let's say pyoderma gangrenosum for both of them. If something happens in the leg, you can Google it, you'll find some pictures of pyoderma gangrenosum actually. Toxic megacolon can happen in ulcerative, whereas fistula obstruction, this thing more common in Crohn's because all four layer involved. I have shown a picture in class. Treatments are discussed earlier already. Great. So that's the end of the ulcerative colitis and the Crohn's disease. This is from the John Murtagh, ulcerative and already shown, and the treatments are given. Sulfasalazine again is the mainstay of the treatment. In very severe cases, azathioprine. There's provision for surgery, but they never ask question regarding that. Guys, are we clear about the you know inflammatory bowel disease? This thing. I think it's a complex one. You definitely this is not as simple as peptic ulcer disease. So this required more practice. I would say about the inflammatory bowel disease. Do not take it so lightly. You can go more deeper. I mean, I gave you the basics, how to start, where to start, where to end. From there, you can study more details. Say, example, if you go to the Davidson's medicine, ulcerative colitis is written in nearly 7-8 pages. That means more deeper things are given there. More typing is also given there, which usually not tested in AMC. But if you want to read more details now, everything is your brain now. You can study whatever you want to study, do it faster. Okay, very important. Next and the last topic for today is a irritable bowel syndrome. Okay, IBS. Now, is this condition is also related to GIT? Yes. What complexities are you expecting in IBS? Can anyone tell me? Most cases in a young female with a this kind of thing, alternative diarrhea and the constipation. So 21 to 40 years, alternative diarrhea and the constipation. Again, it's not a comfortable thing. Sometimes you're having constipation thing, sometimes you're having diarrhea thing, right? So it doesn't really feel good. And mentally also are quite disturbed. Mentally also are quite disturbed actually. So Rome 3 diagnostic criteria something given. It is something relieved by defecation, frequency change, and also certain um, points have been given, often precipitated by eating, anorexia, bloating, distension. All these points are given. All right. So this is something about the irritable bowel syndrome. I'll take you to the irritable bowel syndrome. Just give me a second. We have the note. Yeah. So irritable bowel syndrome note is also available in the note section. You can also check. IBS, so abdominal pain, bloating, looks more like the IBD, right? What is the missing point, guys? If you compare with the IBD, what is that missing point here, guys? It looks quite a similar, like see abdominal pain, the diarrhea. All right, a lot of things quite familiar. Mm, Initially, you don't know ulcer is there or not, but there is another gross finding. So weight loss also comes later in IBD. This is IBS, another very important one, my dear. Come on, guys, 10 more seconds. Bleeding. Yes. Is bleeding is common in IBS? Not really. Blood in the stool. So remember and check next time very carefully. Everyone with IBS experience is unique. So means person to person it varies. So many trials on IBS. If you check, so many trials you'll find. Like Cochrane, then PubMed, so many publications on IBS. Everyone try to find some association with IBS and this and that. So IBS common symptoms, if you can see constipation, diarrhea, sometimes in constipation mode, sometimes in diarrhea mode, feeling of incomplete bowel movement. This is another way. So abdominal pain, bloating, and after going to the toilet, there is a incomplete feeling. All right, for the this condition. So IBS. Okay, so IBS, that's the line we were looking for. IBS not associated with blood. This is the thing. Relieved by bowel movement. All right, relieved by a change in the bowel habit. Okay, so some treatments are given. Diarrhea predominant IBS, constipation predominant IBS. If diarrhea phase is ongoing, you will give some drugs which will stop the diarrhea. Constipation phase, if it is going on, you will give some drug which will stop the constipation actually. At a glance, yeah. It is also related to stress, stress and anxiety a lot actually. So young female, uh, GIT features, some extra GIT features with a mental health affected. So mental health is terribly affected in irritable bowel syndrome. So lifestyle modification is of course, but at the same time, it is very, very important to give like SSRI or this kind of drug for irritable bowel syndrome. Have you ever heard this thing that in irritable bowel syndrome, some these antidepressants or this kind of drugs can be given SSRIs after the lifestyle modification and this and that. Let's go to the John Mortha, almost we are at the end. So irritable bowel syndrome, you'll find that word, the mental things will be mentioned. So pain which is relieved by defecation, which is another interesting thing. Often abdominal pain, but depends on diarrhea usually worse in the morning. So diagnosis of exclusion, hard to make a diagnosis. You can do the colonoscopy, but you don't have a very exclusive findings, right, guys? So do you agree on that point, guys? IBS diagnosis is probably the difficult most because IBD has the ulcer thing at least when you do the endoscopy, but here you have nothing. Yeah. So many things you're doing, but nothing is coming. So you have to keep it in mind. It can be and probably IBS. That is the reason nothing is coming here. All right. So that is why it is written. It is diagnosis of exclusion. After diagnosing everything, then you have to be sure, okay, others are excluding. So that's not the thing. All right, everyone. All right. Today's last but not the least. All right. Lower GIT bleeding. Now, did you know the differentiating point upper GIT and the lower GIT? Where it has been cut, upper and lower GIT. All right. So here is the point. Ligament of Tay is where the upper GIT and the remaining is a lower GIT. Any bleeding coming from this particular parts will consider upper GIT bleeding. Any bleeding comes from this intestinal part, lower part, and these are more, I mean, colorful bleeding. Some which is more close to the rectum and the anal canal is like a fresh bleeding. Like any bleeding coming from rectum or anal canal is like the fresh bleeding actually. Now, can you give me some example of upper GIT bleeding, guys? Okay, esophageal, ulcer, gastric ulcer, peptic ulcer, right? I'm sure you can give me multiple examples. Rupture esophageal varices, bleeding disorders, stomach cancers. Yeah. And there's another one that is the lower GIT bleed. Lower GIT bleed. Yeah, any esophageal bleeding thing, yeah, mallory waste thing, then the stomach related thing and upper part of the duodenum, which is the peptic ulcer, duodenal ulcer thing, also part of the upper GIT bleed. Anything which is the intestinal bleeding ones, like divertic and also diverticulosis, polyp, IBD, colorectal cancer, hemorrhoids, anal fissures. This all goes with the lower GIT bleed. This all goes with the lower GIT bleed. So lower GIT bleed, let's say diverticulosis. I like to address this thing. Diverticulosis is the number one cause in the lower GIT bleed, not the hemorrhoids. Often people say hemorrhoids or the cancer. No, it's the diverticulosis. So diverticulosis and angiodysplasia, these two, like one and two, and then comes the hemorrhoids, the piles, and the cancer, and the infection, this and that actually. Okay, great. So you can check this one, guys, like the lower GIT bleeding causes and what are those causes and how to exclude can be helpful definitely. One of the major bleeding, lower GT bleeding is a diverticular disease. Diverticular disease. We'll end with a CT scan of a diverti. So you'll be given a picture of a diverticular, something like this. Yeah, like a diverticular. You can see the mouse, the patches. All right. So this is a diverticular disease actually. CT scan finding. So very common in the like middle age, lower GT bleed, it can lead to some complication like abscess, perforation, infection, even fistulas. All right. So ruling out is very, very important. So diverticulitis, initial cases antibiotic, then antibiotic drainage. That's important. And later on, you need a surgical procedures actually. More complicated cases, you need surgical approaches. I didn't find extensive treatment coming about diverticulosis, but I have a feeling this year they might give you more advanced one regarding the diverticulitis. So this is the additional slide. I brought it for this particular batch for the diverticulitis. So initially antibiotic, it is related to if there is meningic abscess, if pelvic abscess as well, antibiotic drainage generalized. If peritonitis is very dangerous, then uh, lavage and then the remaining. And if generalized peritonitis is even more dangerous, so Hartmann's procedure in that case. All right, so that's all for the diverticulosis. And also things are given in the notes. Please have a look. Summary, 2 3 things. Let's finish with the bullet point. Most common lower GIT bleeding in infants, anal fissure. If it's an infant, like 1 year kid. Most common lower GIT bleeding in infant is polyp. Okay. Number one cause of lower GIT bleeding, diverticulosis. Number two cause is a angiodysplasia. All right. I hope you liked so far these particular things. Hopefully you enjoyed. So for our today's GIT, we ended with the lower GIT bleeding thing. I hope you can double check the notes. I think it would be helpful actually. So we'll stop here, I think, till here. And if we just double check here for you, if we just double check for you, couple of drawing for the GIT outlined. And here we go, actually. So I think we have done well, and you guys done well along with me. IBD, IBS, and so as the other thing. The cancer thing we'll discuss in future. Cancer thing we'll discuss in future. Yes. Yeah. Yeah, of course, we'll upload the recording actually. Right, guys. So wonderful to know. Also keep eye on because first 3 4 classes we upload in YouTube, then all videos goes to the Facebook group, my dear. So finish it well. I mean, we didn't finish the rectal one because that's a surgical lecture one. If you want to study in advance, you can also open the general surgery lecture one, not a problem. All right. Yes. Access to PDF, you can leave us a message. If you haven't taken admission, you can leave us a message for admission. And if you have taken admission, didn't get no, leave us a message. We'll send definitely. All right. Yeah, this particular, I think the group we are ongoing, about 69, I think the additional members would be removed. Only the doctors who are in the course would remain actually from next week actually. All right. No worries. Give us some time. It will be fine actually. Thank you so much. All right. Good luck. Good night. See you soon. Next Thursday, we have another one. Yeah, that's the thing. And we are going to upload the mock test now for you guys. So you can go through the mock and it will be self-tested. And as we mentioned, after the medicine, we'll be doing the computerized one for you actually. All right. So I'm ending the recording now.